Hi everyone, I welcome you all to this series on General Medicine Revision. I am Dr. Maithreyi, your General Medicine educator. So when it comes to NEET PG, for a student it is about studying 19 subjects, and when you see General Medicine, which is so vast, how would you revise such a vast subject is what would come to your mind. So the aim of this revision program is to provide you with the most high yield topics in a less amount of time, with the limited time that you have, so that you have a higher strike rate in your exams. So I'm very excited to start this session for you. Let's begin. So we are starting with cardiology today. So the format of this session would be, we discuss a previous year question and then we see how to approach that question, and then we also discuss the topics surrounding it. So what are the topics that we will be covering today? We have pulse and JVP, approach to heart sounds and murmurs, ECG, arrhythmias, valvular heart disease, ischemic heart disease, heart failure and cardiomyopathies, pericardial diseases, update on the latest hypertensive guidelines, rheumatic heart disease, infective endocarditis and pulmonary embolism. So these are the most high yield and frequently repeated topics which have been asked in the previous years. Okay, so let's begin. So the first question, which of the following is not true regarding pulsus bigeminis? So to understand what is pulsus bigeminis and to understand this type of question, we should be knowing everything in and around the pulse. Okay, so let us go to the discussion of the pulse and let us attempt this question thereafter. So what is a normal pulse? Pulse is basically the pressure waveform that is generated during the heart's contraction, which is then transmitted across the arteries to the peripheries. So that is what is a normal pulse. So what are the waveforms that constitute the normal pulse? So if we see here, this is the normal waveform. So the upstroke is basically the percussion wave. Following the contraction, following systole, there will be a downstroke, which is the tidal wave. And the wave that is reflected from the peripheral arteries is what is referred to as the dicrotic wave. And the notch that you find here, the notch is called as the dicrotic notch, which is basically because of the closure of the aortic valves. So this is the normal pulse waveform. Okay. So what is the most important thing that you should be remembering with respect to the pulse is the various abnormal pulse waveforms. So let us focus on to this pulse waveform. What are we seeing here? We are seeing a slow upstroke and a late peaking. So what is this slow upstroke and late peaking called? This is the pulsus parvus et tardis. So where do we see this pulsus parvus et tardis? We see it in severe aortic stenosis. Okay. So I hope this is clear. Let us move on to the next pulse waveform. So what do we see here? What do we see here? We are seeing two peaks. So we are seeing two peaks in systole. So what is this pulse waveform called? This is called as pulsus bispheriens. So what are the conditions where we see pulsus bispheriens? It is seen in severe AR, AS with AR and HOCM or hypertrophic obstructive cardiomyopathy. So what is the mechanism behind this pulsus bispheriens? Let us have a look. So let us take, this is the LA, this is the LV and this is the aorta. These are the mitral valves. So what happens during the systole? So during systole, the blood is pumped out from the LV to the aorta. So this is at a high velocity. So this is at a high velocity because of some amount of obstruction that is already present, like in hypertrophic obstructive cardiomyopathy or in aortic stenosis with aortic regurgitation. So what happens is the blood is flowing at a high velocity. So according to this Venturi effect, what happens is when the blood flows in a high velocity, there is a drop in the pressure in the surrounding areas. So when there is a drop in the pressure, what happens is, if you apply the same concept to the LV, the mitral valve, because of the negative pressure, is pulled here and it obstructs the flow of blood towards the aorta. So this is what we call as the systolic anterior motion of the mitral leaflet or the SAM, the famous SAM that you have heard of in HOCM. So this is the basic principle behind this SAM. So what happens is that, how is it reflected onto the pulse? So the first waveform that is generated, the first peak that is generated is because the LV contracts and it pushes out the blood to the aorta against a high resistance. The second peak that happens is that because of this effect, the mitral valve almost closes or causes an obstruction at the level of the aortic orifice. So what happens is the blood has to push against this high pressure, and hence there is a second peak that is developed during systole. This is the basic principle at which pulsus bisvarians is felt. Okay, so this is pulsus bisvarians for you. Now let us look at this pulse wave. What are we seeing here? There are alternate high volume and low volume waveforms. So this alternate high volume and low volume waveforms is what we call as pulsus alternans. So you should not get confused between electrical alternans and pulsus alternans. Pulsus alternans is seen in heart failure whenever the cardiac output is low. Whenever the cardiac output is low, there can be variations in the pulse volume, and this is what we call as pulsus alternans. Electrical alternans basically refers to the alternate values or alternate peaks of the QRS complexes that occur on the ECG. So electrical alternans is an ECG finding, whereas pulsus alternans is a pulse finding. Okay, now let us move on to this waveform. What are we seeing here? So what are we seeing here? Is this pulsus bisvarians? No, just because you are seeing two peaks, it is not pulsus bisvarians. If two peaks are seen in systole, it is pulsus bisvarians. So what are we seeing here? We are seeing a high volume pulse, we are seeing a low volume pulse. So is this pulsus alternans? No. So the key feature here is there is a compensatory pause. Or where is this pulse seen? This is what we call as pulsus bigemini. Right? So basically there are alternate volumes, or there is a high volume and there is a low volume pulse which occurs in an alternating fashion. However, there is a compensatory pause which is seen. This is what is referred to as pulsus bigemini. So this pulsus bigemini is seen whenever there is a VPC or a extra systole which occurs. So there is a normal beat which is carried forward and you get a normal pulse. There is an extra beat or an ectopic beat which comes, which is not reflected in the same way as a normal pulse, and hence the volume might vary. So every ectopic beat is followed by a compensatory pause. So this compensatory pause which you feel in the pulse as an absence, or you find an irregularity in the pulse, but it is regularly irregular. So these pauses will be felt by you in the pulse, and this is what is referred to as pulsus bigemini. Okay, so I hope you have understood how to differentiate pulsus alternans from pulsus bigemini. Okay, what is this pulse wave? So as you can see, there is some variation that is happening during inspiration as well as expiration. So what is this? You can easily guess this is pulsus paradoxus. So what is pulsus paradoxus? Normally there is an inspiratory fall in the blood pressure by up to 10 mm of mercury. So there is an inspiratory fall in the blood pressure. Why is that happening? Because whenever you inspire, there is a negative intrathoracic pressure. The venous return to the heart, which side of the heart? To the right side of the heart increases, and as you all know, the pulmonary system is quite compliant. So there is some amount of pooling of blood in the pulmonary system. The blood does not flow into the LA-LV immediately, right? So the cardiac output can fall for a brief period of time. It does not fall to such an extent that you will have symptoms, but there is a fall in the blood pressure, there is a fall in the cardiac output during inspiration because of pooling of blood in the right side of the heart and in the pulmonary system. So this is a normal phenomenon that is happening. But when there is an exaggeration, when the fall in the blood pressure during inspiration is more than 10 millimeters of mercury, that is what we call as pulsus paradoxus, right? So why is this pulsus paradoxus happening? Let us say we take this condition, constrictive pericarditis or cardiac tamponade. So what happens? There is blood that is in the pericardium which impairs the filling of the heart. So since there is an impairment in the filling of the heart cannot expand any further. So how does the heart expand whenever there is an increased venous return during inspiration? During inspiration, This is the RA, RV. So if the blood increases to the right side of the heart, the septum moves towards the left side, right? So it has to expand at some cost, right? Because it cannot expand into the pericardium. So what happens whenever there is a septal bulge? The cardiac output falls. This is the basic principle behind which how this pulsus paradoxus happens. So where is this pulsus paradoxus seen? It is seen in cardiac tamponade, 1/3 of the cases of constrictive pericarditis. It can be seen in acute asthma or COPD. Sometimes it can also be seen in very severely obese individuals. Okay, so I hope you have understood pulsus paradoxus. Now let us see what is this pulse waveform. What are we seeing here? We are seeing a rapid upstroke and a rapid downstroke. What is this rapid upstroke and rapid downstroke called? This is what we call as the collapsing pulse or the water hammer pulse. So where is this collapsing pulse or water hammer pulse seen? It is seen in majority of the high cardiac output states, right? So it can be seen in anemia, it can be seen in high output cardiac failure, very thyrotoxicosis. It can also be seen in VSD. And where do you find a mini collapsing pulse? A mini collapsing pulse is seen in mitral regurgitation. Okay, so this is pulse for you. Very brief description of the various types of pulses in one slide. Okay, now let's go back to this question. So which of the following is not true regarding pulsus bigeminis? It has to be distinguished from pulsus alternans. Yes, it has to be distinguished. So this is correct. It's a sign of digitalis toxicity. Yes, it can be found in digitalis toxicity. Compensatory pause is absent. So what would be the answer? Which is false? Compensatory pause is present. That is the most important feature which is used to differentiate pulsus alternans from pulsus bigeminis. Okay, and the rhythm is irregular. Yes, it is an irregular rhythm. So we have covered pulse. Now let us move on to the next question. So a young male presents to the ED with history of palpitations. On examination, he is found to have an irregular pulse with an apex pulse deficit of 20. So what is the expected JVP finding in this patient? Now let us just analyze this clinical scenario for a moment. Okay, irregular pulse. So does that ring a bell? Yes. Where is irregular pulse seen? It is seen in atrial fibrillation. What is the importance of this apex pulse deficit? So how do you check for the apex pulse deficit, right? So to check the apex pulse deficit, you need two people. So one of them counts the heart rate and the other person counts the pulse rate. So the difference that you get, the total difference which you get at the end of 1 minute, right? So that is what is referred to as the apex pulse deficit. So if the apex pulse deficit is less than 10, it is generally VPCs. Whenever you have an ectopic, there will be a compensatory pause. So how will the pulse appear? The pulse will appear irregular. So how will you know if this is atrial fibrillation or is it multiple ectopics, right? So that is where this apex pulse deficit comes into play. So if the pulse deficit is more than 10, it is atrial fibrillation. So you all would already know in atrial fibrillation, what is the JVP finding? The JVP finding is a absent A wave. Okay. So it's a very simple question. All you have to do is to get your concepts right and you can answer any question based on this topic. So this brings us to the topic of the jugular venous pressure. So what is the JVP actually? The JVP is basically the pressure waveforms which are well seen in the right internal jugular vein. So basically the jugular venous pressure reflects the pressure changes which are seen in the right atrium and the right ventricle, or the pressure changes which are reflected in the right side of the heart. Okay, so what you should be knowing from the exam point of view is the various waves of the JVP and what are the changes that happen. Okay, so what is the A wave? The A wave is due to atrial contraction. So during ventricular systole, what happens is towards the end of atrial diastole, there comes into picture what we call as the atrial kick. So the atria contracts so that it can empty whatever little amount of blood is left behind in the atrium, right? So this is what is responsible for the A wave in the JVP. Okay. Following that, we have the X descent. The X descent is due to atrial relaxation.